Welcome to Ultrasound the Front Door, the power of POCUS. We're going to be talking about lung ultrasound in COVID-19. It has been invaluable for us over the past 4 weeks as we've seen a surge of patients presenting with COVID. It's helped us make decisions regarding discharge to escalation of care. This is what we have learned at City Hospital from our experience of lung ultrasound and patients with COVID-19. We have been learning from our colleagues from Italy, Spain and China. And as we know that lung ultrasound has better sensitivity than chest x-ray and auscultation, as well as the findings correlate with CT scan. Our patients are really sick, so we can't really take them to CT scan, so this is being used as an alternative. We can use it rapidly at the bedside, it's repeatable and there's no radiation. As I mentioned, it's really helping us empower us with confidence to discharge patients as well as escalate patients for care. Our international colleagues have been leading the way. It is really important that we share learning and knowledge. Additionally, we need to share all the cases and we are still in the process of learning ourselves. So the probes that you'll be using are the abdominal probe, which traditionally we use for chest and abdominal, as well as your vascular probe, which is very good at looking at the pleura. So scanning COVID patients, we do need to think and be careful because of viral exposure and also protective personal equipment, which we know is limited. So what we've been doing in our trust is scanning posteriorly if we can. So just again, as I described in my first video, starting from the back in a lawnmower approach. However, if the patient is very sick, you can scan them anteriorly, but you need to make sure that you are well protected. The other thing that you could do is, whilst you are standing posteriorly, you could come across and scan anteriorly, but stand posteriorly from the patient to make sure that any coughing or any sneezing or anything like that is away from you. Also in COVID-19, we are awake proning our patients, and if we need to scan, it's fine, we can do that whilst they're being proned. And we would just do this in the posterior fashion, like so, and again in the lawnmower approach, scanning downwards, looking for the pathology that we'll be describing later, including B-lines, confluent B-lines and consolidation. And then you can move into the axilla, again looking for pathology. And the same on the other side, moving downwards and down round into the axilla. So this is a really nice slide which depicts the progression of pathology that we will be seeing in COVID. I start off with a normal lung. The first change that happens is the pleura becomes thickened and irregular. Then we start getting B-lines and they progress in number. As they progress, they merge and become coalesced, and then you start getting subpleural consolidation, which is just beneath the pleura. And then as patients get sicker and sicker, they get widespread consolidation. Effusions have been reported to be very rare, less than 10% of cases, and tend to be in the sickest. I'm going to talk through all these changes over the next few slides. So normal lung. We can see here that this is normal lung, and we can see rib, shadow, and normal lung. Normal lung is depicted by A-lines. A-lines are reverberation artifacts, and they are essentially reflections of the bright pleura that we're seeing. Just look here, the pleura is nice and thin and it's sliding, and that's really important to note. So this is normal lung. So the first thing you'll start seeing in COVID patients is thickened pleura. And you can see here, the pleura is thickened, but it is still sliding and moving across. So this is the first thing that you may well start seeing. The next pathology that you'll begin to see are B-lines. Now B-lines are these lines that are seeing, bright lines that you're seeing from the pleura that come all the way down. And it is felt that any more than 2 is pathological. Now there's lots of causes for B-lines, not just ARDS, but also pulmonary edema. Remember, in pulmonary edema, the pleura will be nice and thin, and pulmonary edema you tend to see at the bases. B lines essentially correlate with curly B lines on a chest x-ray. Here's some more examples of B lines, and you can see they're increasing in frequency. As B lines increase, they become coalescent. Essentially, they start merging, and this is what they look like. The lungs start looking more white out because there's less and less air within them. Here is another example. These are all cases that we've seen on the acute medical unit at City. And here we can see severe coalescent B lines, and this patient was very sick. Subpleural changes. So this is consolidation just beneath the pleura. And we can see that the pleura is no longer a straight line, it's moth-eaten. It's breaking away, and there's consolidation and air bronchograms within that. And this is a close-up of that, and you can see it's not that straight line that we were seeing right at the beginning, and there's consolidation there. As patients progress, they start getting lobar consolidation. And here you go, this is an example of lobar consolidation, which is speckled changes, air bronchograms that we can see throughout the lung. And this patient would be very sick because there's hardly any lung that's working. Pleural effusions are noted to be very rare, and they're noted to be in intensive care cases only. Here's an example of what that would look like. So you've got lung here, but as you can you see the speckling? It's actually got mnemonic changes within it. The black space is all fluid, and this is a diaphragm. But this is a paramnemonic effusion with a mnemonic lung there. Recovery. So this is really important because as patients get better, they start getting their A lines back. And here's a case of that. You can see the patient's got A lines, these bright transverse lines, but there are also some B lines as well. But this is a good sign because clinically the patient is getting better, and it can reassure us that things are heading the right way. I'm just going to talk about a few cases that we've seen of lung ultrasound and the usage of it at City Hospital. These are our experiences so far, keen to share them with as many people as possible, and keen for us to learn from you guys as well on what you've been experiencing as well. So where have we been using lung ultrasound? Patient is referred to us, asymptomatic, normal chest x-ray, but referred as suspected COVID. Remember, everybody is COVID consumed. We've been brainwashed by COVID, so everyone coming through the front door has got COVID. But we need to think laterally. So this is a chappie with a normal chest x-ray, and I did a scan, and you can see it's a normal scan. You've got nice bright pleura, sliding, and got A lines throughout, and that scan was normal throughout, and that reassured me the patient could go home. A patient that was symptomatic of COVID but had a normal chest x-ray went on to have a normal scan. So you can see the chest x-ray is essentially normal, but did have a cough and a fever, but was saturating fine. And you can see again, scan the chest, normal pleural line, and got A lines throughout. Patient was reassured and discharged home. Now, this is a very interesting thing that we're seeing, and I know that people have been reporting these. These are patients who have been referred for other reasons, but they are well in themselves. They have no symptoms of COVID, have a normal chest x-ray, but have an abnormal scan. And this is worrying. So this is a normal chest x-ray of the patient, but this was his scan at the basis. Look at that thickened pleural line and the B lines. Patient was very well, not spiking, not lymphopenic. So are these the asymptomatic carriers that are around in the community who are well, but spreading to the more vulnerable? So this is quite interesting phenomena that we have seen. The other thing that we've noticed that, which is quite strange, is that patients with a typical lobar pneumonia don't have consolidation on the ultrasound. Instead, they're having B lines. So this is a 70-year-old chap who, as you can see, he's got some left basal consolidation, and he's COVID positive. He's got typical symptoms. So when we scanned him, I expected to see consolidation, but instead we saw lots and lots of B lines. So is this something that we're just seeing with COVID pneumonia, and they're not having the typical consolidation to initially start with? And there you go, more and more confluent B-lines he had rather than consolidation. The other use that we're using it is for progression of disease. And I've got a few cases. So this is a 44-year-old chappie and he's needing more and more oxygen. This is his chest x-ray. And as you can see, there is extensive bilateral infiltrates. And what's interesting with him is, as I start the scan in the upper zone, he's got B-lines already. He's already got a thickened pleural line as well. And you can see that the B-lines have started from the upper zones and they progress and get worse as I go down to the bases. And we've got some more images there of confluent B-lines. And there we go. So what I found is the sicker patients are, the more pathology we're seeing in the upper zones. This next chappie is 71 and he too was needing more oxygen. This was him when I saw him on day 1 and he was desperate to go home. He was feeling well, he was on 24% oxygen. However, overnight he deteriorated and went on to 15 litres, and this is his x-rays. You can see the changes have really spread and really become more extensive. I scanned him there and you can see that he has got extensive changes. He's got a subpleural consolidation, he's got, extensive B-lines with confluent as well, and that progresses. And you can see there's probably a bit of pleural fluid, which is more marked here. So he's got some fluid as well and lots of B-lines. This gentleman went on to have CPAP and he's still on CPAP at the moment, and he helped me sort of make that decision that things were getting worse, let's try CPAP. But we will beat COVID and there is recovery, and when I see these patients I get very, very happy and excited when I start scanning patients and I can see signs of recovery. This is a professor in engineering and he was really sick when he first came in. You can see there is bilateral changes and infiltrates, and you can see there he's developing his A-lines, they're coming back. And he's still got B-lines, but he's getting his A-lines back, which is very reassuring. The next case is a young chap who, again, that's his x-ray, and you can see he's got extensive pulmonary infiltrates and classic COVID symptoms, and this is his scan, and he's got beautiful A-lines there, reassuring me that I'm happy to let him go home because he's off oxygen and he's getting better. You can see though in the lower zones he's still got some B-lines, but he's well, and this should take time for it to recover. And that's another upper zone for him, and we can see some A-lines. Don't forget about looking for absent lung sliding. We've had a few reports of increased pneumothoraces in patients with COVID, so look for that. Make sure you can see lung sliding, but remember, absent lung sliding is not just due to pneumothorax, it can be due to other things as well. So just to summarise, again, it's really quite easy to do lung ultrasound in COVID. You can pick up the various signs and the progression of that. Don't forget about other pathology. Don't forget about heart failure. Remember, if they've got B-lines and a fusion, this may well be heart failure as well as a thin pleural line. It's helping us reassure ourselves and our patients when we're discharging. It helps us aid in the extent of illness and also decision when we're escalating patients to intensive care. If you have any further questions or you want to share any further cases, please contact us on the various emails and visit our website.